Good afternoon. Thank you everyone for joining us. Today we'll be discussing a significant advancement in addressing the unmet need in essential tremor with Cala's Transcutaneous Afferent pattern stimulation, also known as TAPS therapy, as delivered by the Cala Trio device. My name is Liana Hennem, and I lead the health economics and outcomes research work at Cala Health. Before we get started, I want to highlight just a few quick points. The first is the audience is on mute, as we want to be sure to avoid any background noise. Regarding questions, we did receive some questions in advance of today's webinar, and we will be addressing those at the conclusion of the session during our Q&A. Also, for participants, if you have questions as we go along, please be sure to type them into the Q&A channel, which you see on your Zoom controls, and we'll address any of those questions during the Q&A at the conclusion. And then finally, I want to note that today we will be discussing the on-label use of TAPS therapy in essential tremor, and we will not be addressing any off-label uses for the device. With all of that in mind, let's get started. Our agenda today is as follows. We'll start with an important Medicare update, and then we'll transition to essential tremor. We'll hear from a patient living with essential tremor, followed by an overview of the disease state and the various treatment options in the management of ET. We will then transition to an introduction to the Cala Trio device and the evidence supporting the effectiveness of TAPS therapy in essential tremor. We will then conclude our discussion with a question and answer session. Next slide. So I'd like to start with an important update regarding access to Cala Trio and TAPS therapy for Medicare beneficiaries. Effective October 1st, 2022, CMS issued its final benefit category and payment determination for TAPS therapy, and it was recently updated for 2023. The 2023 payment for the Cala Trio stimulator is $4,183.60, which is the payment for the code K1018 for the Cala Trio stimulator. Cala is receiving payments from Medicare for the device. And this is an important development as it means that Medicare patients now have access to TAPS therapy for essential tremor. Next slide. So I'd like to take a moment to introduce today's presenters. First, we have Ben Duncan. Ben is a retired U.S. Air Force officer with experience in county government and aircraft manufacturing. Being in the human resources profession for 35 years, he has significant experience working with health plans. Ben has suffered from essential tremor for 15 years and is an unpaid patient advocate, helping other ET patients understand the new treatment options available for this devastating neurological disorder. We're also joined by Dr. Praveen Kamani. Dr. Kamani is a movement disorder neurologist and is the medical director of the Movement Disorders Program at Swedish Neuroscience Institute in Seattle, Washington. Dr. Kamani completed his residency in neurology and fellowship in neuromuscular disorders at UT Southwestern. He also completed a fellowship in movement disorders at Stanford University. Dr. Kamani is well known amongst his peers. He's a key opinion leader in the movement disorders neurology community, is a member of the International Essential Tremor Foundation Medical Advisory Committee, and is someone who has significant experience in using TAPS therapy in the management of patients with essential tremor. He has co-authored over 20 peer-reviewed articles, including the most recently published real-world evidence on TAPS therapy, and he participated as a study investigator in the Prospect study, which we'll hear about shortly. Finally, Dr. Dara Khosla serves as the medical director of Cala Health. She completed her neurology residency at State University of New York and her neuromuscular fellowship at Stanford University. She has practiced neurology in California for 13 years, and her research interests lie in bioelectronic medicine and non-invasive medical devices to help patients who suffer from neurological conditions. So I will now turn things over to Ben Duncan to share his experience with essential tremor and TAPS therapy.
Oh, well, good afternoon. My name is Ben Duncan. I'm a Medicare and insurance benefit recipient who has essential tremor. I've been a very successful senior executive in 3 very diverse career fields. My essential tremor developed over 15 years ago. Currently, I use the Cala device, but I have not used it last evening or today so that you can see the severity. And to demonstrate that, I'll show you what it's like. Keep in mind that right now, my tremors are what I call the mild stage. I would wake up in the morning before I started treatment, and I didn't know whether I was going to have a good day, a medium day, or a bad day. But at the same time, during a bad day, the tremors were so bad that my wife would have to spoon feed me. What I like to do is to demonstrate the Cala device to you. It's real simple to use. Basically, you slide it on your wrist, tighten the band, and set the intensity level. So it's starting my treatment now. It's got a score of 0 to 8. I can tell when I'm at the right intensity level, when I feel tingling in my 3 fingers. Having essential tremor for a long time, I couldn't perform basic actions like writing, keyboarding, eating, or even dressing myself. ET forced me to retire early, and it made me seriously depressed, angry, frustrated as my world began to shrink more and more each day. I tried numerous treatments, including being on 3 very strong, expensive Tier 1 and Tier 2 ET medications. I was at the maximum dosage of these 3 medications for over 5 years, but they had serious debilitating side effects. The side effects are balance issues, dizziness, feeling sleepy all the time, forced me to use a walker or a cane for me just to move around. Even with these 3 meds, I only felt like I was about 60% back to my past functioning. As a military veteran, I obtained the Cala device through my local VA clinic. I've been using it for over 2 years, and it has simply been a godsend. It saved my life. I will be showing you the results after my 40-minute treatment session at the conclusion of the presentations. I would like to turn it over now to Dr. Kamani.
Mark, and more than 10 million Americans suffer from essential tremor, which is 10 times as common as Parkinson's disease. The peak age of onset is 40 to 50 years, but it can manifest anywhere from childhood to in the 80s and the 90s. We used to think that the primary symptom and the only symptom of essential tremor was a motor symptom, which was the tremor part, which affected the hands more than any other parts of the body. And a tremor is defined as a rhythmic, involuntary shaking of a limb or any part of the body which interferes with lots of activities of daily living. However, now we know that essential tremor is a complex condition. There are other comorbidities which coexist with essential tremor and are driven, if you will, by the severity of essential tremor, including mild cognitive changes, depression, and anxiety. So therefore, there is a significant burden of essential tremor, not only due to the tremor, which causes significant interference with activities of daily living, including eating, drinking, engaging in self-care, but also because of these other comorbidities, which include psychiatric disorders, substance abuse, and which all adds to the healthcare burden. So given this complexity and comorbidity burden in essential tremor, it is important to have therapies which span the gamut of pharmacological, non-pharmacological, and surgical treatment. Until the innovation of Cala TAPS, we really did not have a good non-pharmacological treatment for essential tremor. I have a feeling that there might be a slide that is missing over here, which I wanted to talk to about the burden of essential tremor. I'm going to see if it is over here under TAPS. Let's see. Okay. So this slide, I think it's important to recognize is one of the most important slides for me, is because it talks about the pharmacological therapy of essential tremor on one end of the spectrum and a surgical treatment of essential tremor on the other end. Pharmacological therapy, as Ben alluded, is not very effective. And it is, if effective, it's only effective in 50% of patients, and 35% of them discontinue it because they're not able to tolerate it, or or the tremor gets habituated with pharmacological therapy. And then you have the invasive surgical treatment with deep brain stimulation and focused ultrasound, which is not accessible to everyone, and less than 1% of people with essential tremor seek it or want to get it. So how do you bridge the gap between the ineffective and the invasive? Well, through innovation, and that's where Cala TAPS comes in. And as Dr. Khosla will tell you in a little bit, it is a non-invasive, very fast-acting wearable technology which can be individualized to the patient's tremor, and we'll see that in a bit. I'm going to go back to the slides. Sorry to jump around a little bit, but I think that slide was out of order. The fundamental rationale for Cala TAPS is the abnormal oscillations that are seen in the essential tremor circuit. They are driven by a group of cells deep in the brain called the thalamus, and the slide shows you a deep section of the brain, a coronal section, in which you see that the portion of the thalamus called the ventral intermediate nucleus, or VIM, which is connected to various parts of the brain and brain stem. This particular portion of the VIM is oscillating at an abnormal frequency, which then is translated into tremor of the hands by way of abnormal electrical messages coming down through the spinal cord and into the nerves that basically control the limbs. And therefore, VIM is the target for FDA-approved therapies, including deep brain stimulation and focused ultrasound, and most recently, the transcutaneous efferent pattern stimulation, or TAPS. I'm going to jump into a case report here of one of my patients who was 55 years of age. And she had a family history of a tremor, and she started with a disabling right hand action tremor early on. This tremor interfered with almost all activities of daily living, including eating, to the point that she was embarrassed to be seen out in public. During her examination, I noticed that she had a fairly moderately severe grade 2 tremor on a very commonly used clinical and research tremor scale called TETRAS. The tremor affected her dominant hand. Her handwriting was not legible due to the tremor. There were no other neurological abnormalities except for a mild neuropathy. And it is important that in our clinic, we make sure that the patient does not have Parkinson's disease, dystonic tremor, medication-induced tremor, or any other kind of metabolic tremor, because the treatment of all of these is different from essential tremor. She was given propranolol, one of the first-line treatments for essential tremor, but due to a slow heart rate, she wasn't able to tolerate it. Primidone caused a lot of dizziness, propranolol and primidone being the two most common first-line medications. She had kidney stones, so topiramate, and a second-line medication, was not an option, and she was already taking gabapentin, another medication for neuropathy, but her tremor was still not effectively treated. She spent a lot of money on assistive devices, including a spoon that rotates at a frequency or oscillates at a frequency which is opposite of the frequency of her tremor. That was not effective. Finally, we did prescribe Cala TAPS to her, and she started using it on a regular basis. And as a result of that, she was able to read, write, drink with ease, and perform all of those activities that she was not able to because of the tremor. And overall, the quality of her life significantly improved. When she came into the clinic, she had her tremor treated with Cala TAPS on the morning of her visit, and I noticed that there was a significant improvement in her tremor. Her writing was legible, which it hadn't been for a while. So what is transcutaneous afferent pattern stimulation? I'll talk about the use of the device in my section, and Dr. Khosla will follow it follow up with this, with illustrating the scientific rationale behind the device. So the Cala TAPS Therapy has motion sensors and gyroscopes and accelerometers, which actually can measure and detect tremor in the outstretched arm position and the proximal arm position. Through that, the device ascertains what the frequency of an individual's tremor is, and then through the process of calibration, generates frequencies frequencies that travel up the median and the radial nerve into the thalamus to disrupt the abnormal oscillations in the thalamus. So it is a very intuitive system. It is customized to an individual's tremor. And it actually acts in the part of the brain, or modulates the part of the brain which is known to be responsible for generation of essential tremor. Often we are asked the question, what is the difference between TAPS and TENS? Aren't they both stimulatory devices? Well, they differ with respect to several things, including the use, the target, the effect, and the durability. TAPS is designed for the relief of hand tremor. TENS is a non-specific stimulator for the treatment of bodily discomfort. The target for TAPS is specifically the thalamus in the brain, and for TENS, it is the local inflammatory tissue or the inflamed tissue. We really don't know how TENS works to calm discomfort down. We know that it just generates electricity. The effect of TAPS is to reduce tremor. The effect of TENS is to produce a sensation and treat discomfort. Again, the mechanism is not known. And the durability of TAPS, as Dr. Khosla will tell you, is at least an hour or more after use, whereas in TENS, the discomfort usually returns right after the device has been turned off. And the two devices look very different as well. The innovative technology of TAPS over here illustrated in the top panel shows you that it has two electrodes, the radial and the median electrode for stimulation, and also a counter electrode, a sensor, which detects the frequency of the tremor to customize tremor treatment. And TENS over here at the bottom has these electrodes which don't have any measurability. They just generate current. So having said all of that, I'd like to hand it over to Dr. Khosla to show us some real life and some science.
So as Dr. Kamani was mentioning earlier, the stimulator has an onboard accelerometer, and that's what measures a patient's tremor, calibrates therapy to that patient's individual tremor frequency, and then delivers electrical stimulation to the patient. The stimulation is transcutaneously delivered by the band to the median and the radial nerves in the wrist. And these bands on the inside part have proprietary dry electrodes, and the bands do need to be replaced every 3 months for optimal functioning. The charging base station, the third component, is cloud connected. It not only charges the device, but also uploads data from the stimulator, which can then be analyzed and used to understand the magnitude of tremor improvement for that patient. Next slide. So patients sign up for their portal access at my.calatrio.com, and they can see details of when they're using the device and how well it's working from them. Patients are able to download this information and print it out and bring it to the next office visit so that their neurologist can review this information. Next slide, please. So there were 2 randomized controlled trials that led to FDA clearance of this therapy. And in all the studies, gold standard assessments were utilized to understand the efficacy of therapy. The first randomized double-blinded study published in 2018, depicted on the left side of this slide, had 10 patients in the treatment arm and 13 patients in the sham arm. And in this study, patients performed a single 40-minute therapy session, and efficacy was measured as a change in the Tetris Archimedes spiral rating. And the spiral drawing is a key component of the essential tremor rating scale. And you'll notice there's a noticeable difference between the spiral from before to after therapy in the treatment patient as compared to before and after therapy in one of the sham patients. The second randomized control study published in 2019, is depicted on the right side of the slide, had 40 patients in the treatment arm, 37 in the sham arm, and patients again performed a single 40-minute session. Here we found significant improvement in the physician-rated essential tremor rating scores, or TETRAS scores, and patient-rated activities of daily living scores. They were significantly different when the treatment group was compared with the sham group. Next slide, please. So in 2020, findings from the Prospect study were published, and this was a prospective home use study, and it was the largest essential tremor study with 263 patients enrolled across 26 sites in the United States. Patients were seen, next slide, please. The patients were seen at 3 in-person office visits, and they had 1 therapy session during each in-person visit. Between the office visits, they were instructed to take the device home and use the device twice a day. Next slide, please. Again, gold standard essential tremor assessment scales were used, namely the TETRAS, and which is the physician-rated essential tremor score, and the Bain and Finley activities of daily living, which is the patient-rated assessment scale. And the co-primary endpoints in the study were change in TETRAS and ADL from pre-stimulation at baseline to post-stimulation at 3 months. Secondary endpoint of this study was at-home kinematic measurements over 3 months. I think we're still on the previous, yeah. And over this 3-month study, over 21,000 at-home sessions were recorded by the devices. And we found a few things, right? So first, we found that patients improved in the TETRAS and ADLs from baseline, so pre-stimulation at visit 1, to study completion or post-stimulation at visit 3. Patients also improved in TETRAS and ADL measurements within each clinic visit. Additionally, we found that the TETRAS and ADL scores improved between pre-stimulation at visit 1 to pre-stimulation at visit 3. And this may imply a cumulative effect over time or some sort of neuroplasticity. And I'm going to come back to that in a few minutes. Some of the other findings in the study included the following. 62% of patients improved from severe or moderate tremor to mild or slight tremor. 68% of patients with severe or moderate difficulty in ADLs improved to mild or better. And most of the improvements were seen in handwriting, pouring from a cup, and holding a spoon, all the things that we all take for granted, right? So next slide. This is a histogram from the Prospect study, and it plots all patients' median improvement in tremor across all sessions. Each line here represents a single patient from the study. And so the key takeaways from this are that 92% of the patients in this study had some improvement in their tremor power. 54% of patients improved by at least 50%, which is actually as much improvement as we see with pharmacotherapies. And 25% of patients improved by at least 70%, which is approximately the improvement that we see in more invasive therapies like deep brain stimulation and focused ultrasound. Next slide, please. So there were no serious adverse events reported in the Prospect study. The most common device-related events were minor, and they included skin irritation, sores, or discomfort at the site of the stimulation. All of these resolved by either reducing or stopping stimulation. And 85% of the patients in a survey reported that it was easy to use the TAPS device. Next slide. So if you recall, one of the findings in the Prospect study was that there was a change in tremor from baseline to 3 months, suggesting some neuroplasticity. And there was a small study conducted at the Mayo Clinic using PET scans to understand whether consistent use of TAPS therapy results in changes in the brain. And this study at the Mayo Clinic, like I said, it was small. It was 5 patients. They had essential tremor. And these patients used TAPS twice a day for 3 months. And in addition to TETRAS clinical rating scores, there were PET scans obtained at baseline and at 3 months. And what they found was that there were changes in the tremor network, specifically in the cerebellum on PET scans after the patients used TAPS twice a day for 90 days. So that's just a small study again, but larger studies to investigate these changes would be helpful. And I believe there are in the works in the future. Next slide, please. So now that the therapy has been on market for a few years, we have collected real-world evidence on usage and efficacy. And this analysis was published actually last year in September of 2022. It was a retrospective post-market analysis of 321 patients who used TAPS for a minimum of 90 days between August of 2019 and June of 2021. And these patients were prescribed TAPS by their healthcare provider, and the device was shipped to the patient's home. They were given written instructions, as well as instructions provided over the phone if they needed, in order to help them set up and calibrate their own devices. And the timing of and frequency of usage was on demand or as needed. So the patients used the device as and when they needed symptomatic relief of their tremor. Next slide, please. The analyses in this study can be put into 3 main buckets. So we looked at usage, efficacy, and patient-reported outcomes as per a survey. Now, usage was summarized as an average number of sessions, at least 20 minutes in duration per week. The second bucket, effectiveness, included the patients and their therapy sessions that met criteria for efficacy analysis, and effectiveness was assessed by measuring improvement in tremor as computed by the accelerometers on the device. And thirdly, the patients reported outcomes that were assessed through a survey that was sent out to patients at 90 days, asking them to report their preference for TAPS therapy relative to existing treatment options, and if they had seen any improvement in their activities of daily living and their quality of life after using TAPS. Next slide. So this slide is a little busy. I just wanted to quickly review some of the important population characteristics of these patients in the real world analysis. Out of the 321 patients, average age was 71, 32% were female, and the majority of prescribing physicians were movement disorder specialists or neurologists, although there were some family practice and internal medicine and even occupational therapists who prescribed the device. Some of the additional population characteristics were captured from the patients who responded to the survey, and the majority of patients who did respond to the survey had a history of tremor for over 5 years, and they rated their tremor as being moderate or severe. 88% of the patients said that they had tried medications prior to using TAPS therapy, and 62% of them said that they were taking medications along with TAPS. And finally, they identified activities of daily living as being their greatest area of therapeutic need. Next slide. Again, looking at the results, let's think about it in 3 buckets, right? So the usage, effectiveness, and patient-reported outcomes. So over 70,000 therapy sessions from those 321 patients were included in the usage analysis. And 216 patients performed over 9,000 sessions that met the criteria for effectiveness analysis. The criteria for inclusion in the effectiveness analysis required that the patients performed at least 10 sessions that included the pre and post stimulation measurements. The sessions had to be at least 20 minutes in duration, and they had to have minimal artifact in order to be included for this effectiveness analysis. And we also did exclude back-to-back sessions and sessions that had incomplete measurements and that had motion artifacts. As far as usage, the total usage period ranged from 90 to 663 days. And 28% of the patients included in this analysis had been using TAPS for greater than a year. So patients used TAPS on demand, an average of 5.4 times a week over their total use period. And the use of TAPS from 6 months to a year remained high at 4.6 sessions per week. And as far as effectiveness goes, here to the right, you can see that 93% of the patients had at least some reduction in tremor. 59% of patients had at least 50% reduction in tremor. And 31% of patients had at least 75% reduction in tremor. And if you remember, these numbers are very similar to the prospective study. Significant habituation was not observed in this analysis. So we looked at patients who had used within 90 days and then efficacy post 90 days, and there was no significant habituation seen. Next slide, please. So as I mentioned earlier, patient-reported outcomes were assessed by a survey that was sent out 90 days after patients had been on TAPS. And 84% of the patients who responded indicated an improvement in at least one of 3 key ADLs. 65% of the patients reported improvement in quality of life with TAPS therapy. And moving over to the right here, 65% of patients preferred TAPS therapy to other treatment options. And importantly, of the patients taking medications for their tremor before trying TAPS, 24% of them were able to either reduce the dose or discontinue their medication after 3 months of TAPS use. And this is especially critical for these patients who take multiple medications. Next slide, please. Complaints regarding the device-related safety events were consistent with the adverse events that were reported in the previous clinical trials. Here, 12% of patients reported a safety-related complaint, and they were all mild, again, skin irritation, discomfort, and there were no severe safety events reported. So next slide. In summary, in the Prospect trial, patients experienced statistically significant improvements in patient and physician rated scores in the TETRAS and ADL scores. In the real-world analysis, we saw that TAPS therapy usage and effectiveness is consistent over time. There's no evidence of habituation over repeated use, and there were significant improvements in activities of daily living and quality of life. And these findings on effectiveness and safety from the real-world evidence analysis are consistent with the findings from Prospect and the earlier randomized controlled trial, so that we see that clinical benefit for patients really translates well from the investigational setting into the real world. Next slide. So when should we consider TAPS for our patients? The International Essential Tremor Foundation, it includes TAPS therapy as an add-on or follow-up to first-line therapy in their treatment recommendations. And they recommend that physicians consider adding TAPS to propranolol or primidone, or using TAPS after their patients have tried and failed propranolol or primidone. They also recommend that it's considered before second and third line treatments, and it should be considered before any invasive procedures like DBS or focused ultrasound. Next slide. And as some of you know, Up to Date is a service that a lot of physicians use. It provides evidence-based resources for healthcare professionals to help them in their clinical decision-making process. And Up to Date cites the Prospect study and recommends that patients with disabling tremor who have suboptimal control on meds, or those who are not candidates for other treatments, are good candidates for TAPS therapy. And ECRI is a healthcare technology assessment firm. They recently updated their assessment of Cala TAPS Therapy based on our evidence from Prospect and the real world evidence study. ECRI just upgraded their assessment in support. I'm not sure where we are with your therapy session, but if you would demonstrate the tremor again, we'd love to see how you're doing.
Okay. Thank you. I've finished my therapy session. Okay, there I am. And just to show the difference, here's after the session. You saw me with my glasses before, shaking all around. By using the Cala device, I feel like I'm 98 to 99% back to my full functioning. I feel like being off the medication and side effects, I feel 20 years younger, which is great. I've weaned myself off all 3 of the expensive ET medications, and I don't experience their debilitating side effects. I can walk upright without using a cane or a walker. One of the things that I would like to emphasize is that the Cala device was clearly designed for tremor patients in mind. Unlike other assessment and treatment devices where you have leads or electrodes and you have to sit still for a session, I can have a treatment session and continue with my daily activities. And this has been a really important thing. If I had to have leads and electrodes and sit still, I would not use that continually at home. The important thing is that it has really improved my quality of life. This means I am able to use the treatment device multiple times a day, anytime I need it. I've had great results over the last 2 years. This device automatically, and it was mentioned before, adjusts my band to my specific needs. This information, like was said, was is through the cloud upgrade, sent up to Cali Health. The other nice thing is that I can go into the portal like it showed and see my progression. And this becomes a great motivator for me. Without an effective tremor treatment, this disease strips a person of their self-worth, their self-confidence, and robs each person's self-identity. As a person's world shrinks, they're not able to do what they used to, it can lead to other problems like alcohol abuse, PTSD, or even thoughts of, why should I go on and continue to live? I know, I've been there. That is why I am an unpaid patient advocate, so that others may not have to go through and experience the harmful, debilitating effects of ET like I did.